Hi, welcome to my ECG video blog. I'm Ken Grauer, and this is my 11th ECG video blog. This is part 2 in my series on the basics of rhythm diagnosis. In this video, we'll pick up where we left off in part 1. So feel free to go back and review part 1 at any time if questions arise. I'll again emphasize that my focus in this video series is on the basics of rhythm diagnosis. That said, there are plenty of pearls sprinkled in along the way for more experienced interpreters, so hopefully there will be plenty of helpful material for anyone viewing. For your convenience, I've made a web page on cardiac arrhythmias that lists key links to my materials at www.aafpecg.com. Above all is my email address. Please write me with your comments, feedback, and questions. On to today's topic. In part 1, we laid the foundation for our basic approach to rhythm interpretation. We began by stressing the importance of the clinical scenario. What to do at the bedside will obviously depend on whether the patient in front of you is alert and hemodynamically stable or unstable with hypotension and/or impaired consciousness. We then introduced our systematic approach for interpreting the rhythm, which is based on assessment of the 5 key parameters. These are conveniently remembered by the phrase, watch your P's, Q's, and the 3 R's. Let's now apply this approach to interpretation of the basic supraventricular arrhythmias. We'll start easy with the most basic of rhythms. Much more important than jumping to the correct answer is the process. So we'll think along with you step by step as we work through each answer. I'll emphasize that this is exactly what I still do with every rhythm that I interpret. That is, look for P waves, determine if the QRS complex is wide or narrow, and assess the 3 R's of rate, regularity, and if P waves are present, whether P waves are or are not related to neighboring QRS complexes. With practice, this process becomes automatic, and rather than slowing you down, it actually speeds up the process of rhythm interpretation, with decided advantage that you won't miss major findings. On to the first example. How would you approach this first rhythm? You can assume that all patients I present are hemodynamically stable unless I specify otherwise. Be sure to be systematic in your interpretation, even if you instantly know what the rhythm is. We'll think out loud with you. Since this patient is stable, we have time to assess the rhythm. We need to assess 5 parameters, but it doesn't matter in what sequence we look at them as long as we eventually look at all 5. So we usually start with whichever parameter is easiest to assess, which could be any of them for this first basic rhythm. And sometimes you'll find that several parameters are simultaneously assessed with a single glance. But even when you instantly know what the rhythm is, be systematic. The rhythm appears to be regular. We do see P waves, and these P waves are upright in lead 2. There is a constant PR interval preceding each QRS complex, so each P wave is related and being conducted to the ventricles. And the QRS complex is narrow because the QRS is clearly not more than half a large box in duration. The only parameter that we've not yet addressed is the 3rd R, or the rate. Since the rhythm is regular and the R to R interval is about 6 large boxes in duration, the rate is 300 divided by 6, or 50 per minute. So we've established that the rhythm is sinus, with upright and conducting P waves in this lead 2. We've also established that the QRS complex is narrow, so that at least from the single lead there appears to be no bundle branch block. But the rate is less than 60 per minute, so we say that the rhythm is sinus bradycardia. What now happens? The rhythm shown here is very similar to the one we just showed, with one major difference. But it's easy enough to treat this like a new rhythm and simply run through the 5 parameters again. The rhythm is regular, and the QRS complex is narrow. The R to R interval is about 6 large boxes in duration, so the rate is 300 divided by 6, or about 50 per minute. Are there P waves? The obvious answer is yes, red arrows, as shown by the regular occurrence of similar-looking upright P waves in this lead too, which leaves us with the last parameter. Are the P waves we see related to neighboring QRS complexes? To answer this question, we look in front of each QRS complex on the tracing to see if it is preceded by a P wave, and if so, whether the PR interval is constant. And it is. So the rhythm is sinus bradycardia. But what is the PR interval? Remember in part 1 that we introduced the measurements used on standard ECG grid paper, where each large box took 0.20 second to record. Looking closer, each small box on ECG grid paper takes 0.04 second to record, so that there are 5 small boxes within each large box. For practical purposes, the upper limit of normal for the PR interval in adults is 0.20 second, which consists of the amount of time it takes to record one large box. This is convenient because it allows us to tell at a glance if the PR interval is normal or long. The PR interval is long if it is more than one large box in duration. We call this first-degree AV block. Looking at this case, this is one large box on ECG grid paper. The PR interval is clearly longer than one large box for this rhythm. We estimate the PR interval to be about 0.30 second. Therefore, this is first-degree AV block. The complete interpretation for this rhythm is sinus bradycardia with first-degree AV block. How about this rhythm? By now, you should be comfortable recognizing when a sinus mechanism is present, which should quickly be evident by the presence in lead 2 of upright, similar-looking P waves with a fixed and constant PR interval. That said, we should always address all 5 of the key parameters before making a diagnosis. And so far, we've only looked for P waves and their relationship to the QRS. Looking at the other parameters, the QRS complex here is clearly narrow, which leaves us to decide on the rate and regularity, or lack thereof, for this rhythm. This rhythm is not regular. This should be readily apparent from the difference in R to R interval from one beat to the next. Technically, sinus rhythm may vary by up to 2 to 3 small boxes, or 0.08 to 0.12 second, from one beat to the next. But the degree of variation in R to R interval that we see here is clearly more than that amount. So the rhythm is sinus because upright P waves with fixed PR interval are consistently seen preceding each QRS complex in this lead too. But the rhythm is irregular. We call this sinus arrhythmia. There is no need to specify the rate because by definition, the rate will change from beat to beat, although sometimes a rate range may be given. Note, it is especially common to see some variation in R to R interval when the rate is slow, as shown here. We call this rhythm sinus bradycardia and arrhythmia. Sinus arrhythmia is a common normal variant rhythm, especially when it occurs in a benign setting. In young children at rest, it is the rule rather than the exception to see some variation in rate from beat to beat. You can verify this yourself by listening to the heartbeat of healthy young children, in whom this benign sinus arrhythmia will often be associated with the child's respiration. But on occasion, sinus arrhythmia, especially when associated with bradycardia, may be pathologic, as this may be one of the earliest manifestations of sick sinus syndrome. This highlights the point we emphasized at the very beginning of this video series, namely that we cannot interpret arrhythmias in a vacuum without being given at least a brief clinical history. Let's complete our review of the sinus mechanism rhythms with a few words about rate and QRS duration. This is sinus tachycardia. By the P's, Q's, 3R approach, the rhythm is regular, the QRS complex is narrow, similar looking upright P waves with fixed PR interval precede each QRS complex in the tracing, and the definition of tachycardia is fulfilled because the rate of the rhythm is over 100 per minute. In this case, the R2R interval is a bit less than 3 large boxes in duration, so the rate is slightly more than 300 divided by 3, or slightly over 100 per minute. Once we define the mechanism of the rhythm as being sinus by the finding of upright conducting P waves in lead 2, red arrows, the type of sinus mechanism rhythm is determined by the rate and regularity of the rhythm. Normal sinus rhythm has a rate between 60 to 99 beats per minute. Sinus tachycardia in adults is defined by a sinus rhythm with a rate of at least 100 per minute. If the rate is less than 60 per minute, then we call the rhythm sinus bradycardia. And if R2R intervals are clearly irregular, as they were for the previous example, then we are dealing with sinus arrhythmia. So what if the QRS complex is wide? The point to emphasize is that we go through the identical diagnostic process as with any other rhythm. Once we ensure that the patient is hemodynamically stable, we know there is time to systematically assess the rhythm without having to worry about immediate cardioversion. Looking at this rhythm, the QRS complex looks to be wide. That is a bit more than half a large box in duration. Continuing with the P's, Q's, 3R approach, the rhythm looks to be regular. Similar looking upright P waves again precede each QRS complex in this lead 2 with a constant and normal PR interval, and the rate of the rhythm is about 100 per minute. So the rhythm is sinus tachycardia with QRS widening due to the presence of bundle branch block. This is very different than this similar looking rhythm with QRS widening, with the difference being that there are now no P waves in this lead 2. By the P's, Q's, 3R approach, we have a regular wide QRS tachycardia at a rate of 100 per minute. Since the patient is stable, we would want to obtain a complete 12-lead ECG during the tachycardia to see if atrial activity might be evident in other leads. But the fact that no P wave at all is seen in lead 2 during the tachycardia means that the rhythm is not sinus tachycardia. As we'll see in part 3 of this video series, this is probably an accelerated ventricular rhythm. Let's apply what we've covered thus far to the interpretation of this rhythm, which will lead us into the concept of escape. Again, the patient is hemodynamically stable, and unfortunately, we again only have a single lead 2 rhythm strip. Given this scenario, what can be said about the rhythm? Our answer is most easily organized by the P's, Q's, 3R approach. The rate is slow and the rhythm looks to be fairly regular. What about P waves? We see no P waves in this lead 2 rhythm strip. What about the QRS? The QRS is clearly narrow, as it is definitely not more than half a large box in duration. What does that tell us? As we discussed in part 1 of this video series, and assuming that the QRS is truly narrow in all 12 leads of this patient's ECG, knowing that the QRS complex is narrow tells us that the rhythm is supraventricular, that is, originating from at or above the AV node, or from at or above the double dotted line in this figure. The number of possibilities is limited. They essentially include sinus rhythm, an atrial rhythm, or an AV nodal rhythm. This rhythm is not sinus because there is no upright P wave in this lead 2. It is also unlikely to be an atrial rhythm because we don't see any P waves at all in this lead 2. This essentially defines this rhythm as an AV nodal escape rhythm. Once we've established the presence of a non-sinus rhythm, we look next to determine the rate of this rhythm, since the rate provides insight as to whether we are dealing with a fortuitous, happy that it occurs, escape rhythm, or an accelerated and potentially worrisome non-sinus focus that arises because of ischemia, infarction, drug toxicity, or some other pathologic cause. The important rate ranges to keep in mind are easy to remember. They are the following. Normal sinus rhythm is defined by a rate between 60 to 99 beats per minute with a rate of 100 per minute or more constituting sinus tachycardia. This is for adults, since the norms for pediatric patients will be different depending on the age of the child. If the SA node fails, then we hope that some other focus in the conduction system will take over. Most often, this will be the AV node, which we call an AV nodal escape rhythm. The usual rate range for an AV nodal escape rhythm is between 40 to 60 per minute in adults, which is consistent with the rate of the AV nodal rhythm we see here. But what if the AV node also fails? In this case, we have to hope that a lower focus will come to the rescue with an escape rhythm, because if it doesn't, the resulting rhythm might be asystole. So if the AV node fails, we hope for emergence of a ventricular escape rhythm, which in adults will typically manifest a wide QRS complex with an escape rate of between 20 to 40 per minute, as it does in this example. These escape rate ranges are important to remember. Fortunately, they are easy to recall. We know the rate range for sinus rhythm, which is 60 to 99 per minute. The rate range for ventricular and AV nodal escape is stepwise with respect to the sinus rate range. That is 40 to 60 per minute for AV nodal escape and 20 to 40 per minute as the typical rate range for an idioventricular escape rhythm. Let's put these concepts together with this tracing. What is the rhythm? As always, we need to resist the urge to jump at a specific rhythm diagnosis and instead systematically address ECG findings by the 5 parameters of the P's, Q's, 3R approach. The rhythm in this tracing looks to be regular. The rate is fast, with an R to R interval that is slightly less than 3 large boxes in duration. Therefore, the rate is slightly over 100 per minute. Normal sinus P waves are absent. That's because there is no upright P wave preceding each QRS complex in this lead 2. How about the QRS complex? The QRS appears to be narrow, but is it? What is this? Whatever it is, it appears to be present at the end of each QRS. Since we've been talking about P waves, one wonders if this negative deflection at the end of each QRS complex might be a retrograde, that is, conducting backward P wave. But couldn't it also represent the terminal part of the QRS complex itself? Remember our emphasis in Part 1 on the statement, 12 leads are better than 1. This is clearly one situation in which we need a 12-lead ECG in order to determine what the negative deflection within the blue circle truly is. For simplicity, let's say that a 12-lead ECG confirmed that these negative deflections, red arrows, do represent retrograde P waves in this tracing. Therefore, since we now know by the P's, Q's, 3R approach that this rhythm is regular, with a narrow QRS complex, and without normal sinus P waves, we have defined this as an AV nodal rhythm. Is there anything unusual about this AV nodal rhythm? The answer is the rate, which is simply too fast for an AV nodal escape rhythm. As emphasized in the previous slide, it's important to remember the usual rate range for escape rhythms. The normal AV nodal escape rate is between 40 to 60 per minute. The rate here is much faster than that, so the rhythm is AV nodal tachycardia. Terminology. For practical purposes, realizing there are some semantic anatomic differences, when we use the term AV nodal, we could equally well use the term junctional. So we could equally well talk about premature AV nodal or junctional contractions, and we could interchange description of a rhythm as being either AV nodal or junctional escape. On the ECG, we may see one of three manifestations of P waves when dealing with junctional beats or junctional rhythms. These are the following. A negative P wave may precede the QRS complex in lead 2. There may be no P wave at all in lead 2, or a negative P wave may follow the QRS in lead 2. Understanding the rationale for these three P wave possibilities is best explained by use of a laddergram. Learning to draw laddergrams is a challenging advanced concept that clearly extends beyond the scope of this basic video on ECG rhythms. But learning to read laddergrams is easy. My purpose in introducing laddergrams at this basic stage in rhythm interpretation is to show how easy they are to read and how highly instructive they can be. Please do not be intimidated when you see a laddergram. There are three tiers in a laddergram, representing passage of the impulse through the atria, through the AV node, and through the ventricles. There's actually a fourth tier to represent that the impulse with normal sinus rhythm starts from the SA node, but this SA nodal tier is usually not drawn into the standard laddergram. The final element incorporated into the laddergram is the element of time. We schematically illustrate the passage of time along the horizontal axis. Simply stated, a laddergram explains what happens as the electrical impulse is conducted through the heart. A look at corresponding anatomic events should make this clear. With normal sinus rhythm, the impulse begins in the SA node, after which the impulse travels via specialized intra-atrial pathways to arrive at the AV node. The reason the P wave is upright in lead 2 with normal sinus rhythm is that the path of the impulse, as viewed from lead 2 at plus 60 degrees, is virtually parallel to the direction of depolarization from SA node to AV node. After arriving at the AV node, the impulse is then rapidly conducted through the ventricles. So normal sinus rhythm on a laddergram looks like this. Rapid conduction through the atrial tier, with fast conduction schematically drawn as a vertical blue line, slower conduction through the AV node, represented by this blue line drawn in at an angle, and then rapid conduction through the ventricles. Note, although we added in 2 red circles to represent the SA node and the AV node, these are typically omitted on an actual laddergram. What then happens with AV nodal rhythms? Now the impulse starts in the AV node. From there, the impulse conducts normally down to the ventricles, but it also conducts retrograde, that is backward to the atria, so that from the perspective of lead 2, the impulse is moving away from lead 2, which is why the P wave in lead 2 with junctional rhythms will be negative. Let's look at this on the laddergram. The red circle within the AV nodal tier represents origin of the impulse within the AV node. This AV nodal impulse is normally conducted down to the ventricles, blue slanted line. The impulse is also conducted back to the atria, yellow line. If the relative speed of conduction back to the atria is faster than conduction down to the ventricles, then a negative P wave will appear before the QRS in lead 2. If, on the other hand, the speed of conduction back to the atria takes longer than conduction down to the ventricles, then a negative P wave will appear after the QRS in lead 2. And if it takes about equal time for the impulse to travel down to the ventricles as it does back to the atria, then no P wave at all will be seen in lead 2. So these are the 3 possibilities. The most common situation, by far, is the middle one, in which no P wave at all is seen in lead 2 with junctional beats or junctional rhythms. The least common is the last situation, in which a negative P wave follows the QRS. In our experience, it is rare to see this, although we showed you an example for the junctional tachycardia seen in the previous slide. So how should we assess this rhythm? Looking systematically, the QRS complex is narrow, so the rhythm is supraventricular. The rhythm appears to be regular. What about atrial activity? Given that we are looking at a lead 2, we can say that normal atrial activity is not present because the P wave is not upright in this lead 2. But P waves are present, and these P waves are conducting because they are seen to precede each QRS complex with a fixed PR interval. So this regular, non-sinus, supraventricular rhythm appears to be an example of the junctional rhythm we showed on the previous slide, in which negative P waves precede each QRS in lead 2 with a short but constant PR interval. Is there anything unusual about this AV nodal rhythm? Hint: what is the rate? As shown, the R to R interval is 4 large boxes, so the rate is 300 divided by 4, or 75 per minute, which, as we just discussed, would constitute an accelerated junctional rhythm, because it is faster than the usual junctional escape rate range of between 40 to 60 per minute. That said, are you certain this is an AV nodal rhythm? Let's answer this by considering the following. With a junctional rhythm, the impulse begins in the AV node. With respect to lead 2, atrial activity will be seen as moving away from lead 2, which is why P waves are negative in lead 2 with the junctional rhythm. But what if the site of impulse formation was from low down in the atria, blue circle? In this case, activation of the atria might still be viewed as moving away from lead 2, and therefore a negative P wave might again be recorded in lead 2. So this rhythm that we show could be an AV nodal rhythm, Or it could also be an ectopic atrial rhythm, perhaps arising from the coronary sinus. We just cannot tell for certain on the basis of this single rhythm strip tracing. Let's now switch gears and look at another category of rhythms, beginning with this tracing. By the P's, Q's, 3R approach, the QRS complex is narrow, and P waves are absent in this lead too. As opposed to the junctional rhythms that we have just reviewed, this rhythm not only lacks normal sinus P waves, but it is also irregularly irregular. With practice, it becomes easy to recognize that each R2R interval is different from the next. To facilitate our discussion, we have measured out each R2R interval for you. But the key point to make is that the presence of an irregularly irregular rhythm without P waves in any of the 12 leads defines a rhythm as atrial fibrillation. Note, be sure you have looked at all 12 leads on the ECG before you diagnose the rhythm as AFib. This is because atrial activity may sometimes only be seen in other leads. Note also that simply saying this rhythm is AFib is an incomplete answer. We need to also include mention of the ventricular response. In this case, the complete answer would be AFib with a controlled ventricular response. We say this because the R2R intervals that we do see on this tracing suggest that the average rate for this example of AFib is somewhere between 70 to 110 beats per minute. Rate estimation on a short rhythm strip like this one is of course no more than a rough approximation. Nevertheless, looking at the range of R2R intervals with AFib does provide insight as to the overall ventricular response. Question: is this still AFib? This new rhythm is once again fast, the QRS complex is still narrow, and no P waves are seen in this lead too. But isn't it now much more difficult to tell by a simple quick glance whether this rhythm is or is not irregular? Pearl: when the rate of AFib is rapid, the rhythm may look regular even though it isn't. That's the case here, when closer inspection is needed to confirm that the R2R interval actually continues to vary from beat to beat. Thus, this rhythm is still AFib, and not PSVT as one might think if R2R intervals were not carefully measured. AFib is the most common sustained cardiac arrhythmia seen, and its incidence continues to increase as our population ages. It's therefore worthwhile to spend a few extra moments on ECG recognition. Complete description of AFib entails specification of the ventricular response. For example, this is rapid AFib, in which the average rate is 120 to 130 per minute or more. We know the rate is this fast because the R2R interval for most beats on this tracing seems to be between 2 to 3 large boxes in duration. In contrast, this is AFib with a controlled ventricular response, in which most R2R intervals are between 3 to 4 or so large boxes in duration, which corresponds to a ventricular rate range that generally falls between 70 to 110 per minute. At the other end of the spectrum, this is AFib with a slow ventricular response, which corresponds to an average rate below 50 to 60 per minute. Question: which ventricular response to new onset AFib is most common in clinical practice? The answer, by far, is that new onset AFib is most likely to present with a rapid ventricular response. This is important clinically because treatment decisions depend upon the relative rate of the ventricular response. When the response is rapid, as seen here, then treatment priorities center around slowing the rate. In contrast, new onset AFib with a slow ventricular response, as seen here, often entails cardiac pacing if a potentially reversible cause of the bradycardia is not found. So, what's this within the red rectangle? These are fib waves that are due to the numerous tiny amplitude undulations of atria fibrillating at a rate between 400 to 600 impulses per minute. These fib waves are more coarse in this middle example of AFib, whereas the fib waves are fine in the lower tracing. And fib waves are not really seen at all in parts of the top tracing within the blue rectangle. I like to see fib waves when the rhythm is irregular because this helps to confirm that the rhythm is AFib. When fib waves are absent, then ECG diagnosis of AFib may be more difficult as it entirely depends upon recognition of an irregularly irregular rhythm without P waves in any of the 12 leads. So, this supraventricular rhythm is irregular, but despite being irregularly irregular, this rhythm is not AFib. Why not? Once again, the answer resides in the P's, Q's, 3R approach. There are P waves, so this rhythm can't be AFib. And as we look at these P waves, they are all different shapes with different PR intervals, schematically represented here by different colors. Some P waves are positive, some are negative, and some are biphasic. This is MAT or multifocal atrial tachycardia. The name tells all. There are multiple sites in the atria that are continually discharging at a rapid rate. The cause is usually hypoxemia from severe pulmonary disease or occasionally from severe metabolic disturbance due to an acid base and/or electrolyte disorders. Treatment is directed at trying to identify and correct the precipitating cause. MAT is usually easy to diagnose when multiple different P waves are continually noted in an irregularly irregular narrow QRS rhythm. But P waves will not always be evident in all leads. And if P waves are not well seen in the one lead you happen to be monitoring, it would be easy to misdiagnose MAT as AFib. This is important clinically since treatment of MAT and AFib is quite different. For example, consider this 12-lead ECG. The diagnosis of MAT is obvious if one looks at lead 2, but if leads other than lead 2 were being monitored, distinction from AFib might be nearly impossible to make. Overall, AFib is much more common than MAT, but because of the different approach to management, it's important to recognize MAT when it does occur. The keys for recognizing MAT are the following. First, think of MAT when you see an irregular rhythm in the right clinical setting for MAT, which most often involves a patient with severe pulmonary disease and/or a very ill intensive care patient with multi-system disorders. Then get a 12-lead ECG, since this is the only way that you'll be able to determine if multiple different looking P waves are or are not present on the tracing. Let's move on to a different supraventricular arrhythmia, which we show in this rhythm strip. As always, once we ensure that the patient is stable, we utilize the P's, Q's, 3R approach to assess the 5 key parameters. Let's start with regularity. The rhythm looks regular, and the QRS complex appears to be narrow. But is it? Could this negative deflection within the red circle be part of the QRS? It turned out that this negative deflection was not part of the QRS, but it was only after we obtained a 12-lead ECG done during the tachycardia that we knew this for certain. So we needed a 12-lead ECG in this case. in order to be certain that the QRS complex was narrow and that the rhythm was supraventricular. Are there P waves? Or should I say, is there evidence of atrial activity? You might think that this positive deflection immediately preceding the QRS is a P wave, red arrow. But if so, then wouldn't the PR interval be a bit short to conduct? How about this negative deflection, blue arrow? And how about the possibility that all of the negative deflections we see on this tracing might represent atrial activity? The bottom line is that we simply can't tell for sure about the presence or nature of atrial activity on the basis of this single tracing, which raises the question as to whether there is some diagnostic maneuver that we might do to facilitate diagnosis. We could do a vagal maneuver, such as carotid massage or Valsalva, which was done at the large red arrow. This is the response. The vagal maneuver temporarily reduces AV conduction, thereby slowing the ventricular response. This allows us to confirm regular atrial activity at a rate of about 300 per minute, blue arrows. The only thing that does this is atrial flutter. The hallmark feature of atrial flutter on ECG is the presence of sawtooth atrial activity at a perfectly regular atrial rate that is close to 300 per minute, as shown by the blue arrows. We emphasize the following points about ECG diagnosis. First, atrial flutter is by far the most commonly missed arrhythmia diagnosis. The atrial rate is most often close to 300 per minute, with a usual rate range in adults between 250 to 350 per minute. This is easy to see on ECG because a rate close to 300 per minute approximately corresponds to the occurrence of one flutter wave after each large box. Note, this is for untreated atrial flutter. The flutter rate may be a good bit less than 300 per minute if the patient is on an antiarrhythmic medication such as amiodarone. The most common ventricular response to untreated AFlutter is with 2-to-1 AV conduction, which means that the ventricular rate will usually be close to 150 per minute, as it is during the early part of this tracing. The next most common AV conduction ratio is 4-to-1. Odd conduction ratios, such as 1-to-1 or 3-to-1, are rare. So, given that AFlutter is the most commonly missed arrhythmia diagnosis, the best way we know not to overlook this diagnosis is to think of it whenever you are confronted with a regular supraventricular tachycardia at a rate close to 150 per minute, but without normal sinus P waves. The last arrhythmia we present in this part 2 of our video series on basic rhythms is this one. The patient is again stable, and we again use the P's, Q's, 3R approach for interpretation. The rhythm is fast, but it appears to be regular, and normal sinus P waves are absent in this lead too. Actually, we can't tell if the upright deflection within the blue circle is a T wave, P wave, or perhaps a combination of the two. But we can say that a clearly distinct normal sinus P wave is not seen. The QRS complex appears to be narrow, at least as best we can tell from the single lead rhythm strip. What about the rate? To determine the rate, we'll pick a QRS complex that begins or ends on a heavy line and count the number of large boxes that it takes to record 2 beats. This is the every other beat method. It takes 3 large boxes to record every other beat. Therefore, half the rate equals 300 divided by 3, or 100 per minute. The actual rate is twice that amount, which is 100 times 2, or 200 per minute. The rhythm is PSVT, which stands for Paroxysmal Supraventricular Tachycardia. Another, probably better name for this rhythm is AVNRT, or AV Nodal Reentry Tachycardia. For our purposes, we'll treat these two terms as synonyms. The important concept for this rhythm is reentry. PSVT, or AVNRT, is a reentry SVT rhythm. Most often, reentry is started by a premature beat, typically a PAC. This premature atrial impulse is conducted to the AV node, where, if conditions are just right, a reentry circuit may be set off. The reentry cycle is usually contained within the AV node, unless the patient has WPW, in which case a portion of the reentry circuit is conducted over the accessory pathway. Typical AV nodal reentry goes like this. The impulse is caught within a continual circuit within the AV node. Each time the impulse arrives near the top of the AV node, it conducts retrograde back to the atria. Each time it arrives at the lower portion of the AV node, it gives off an impulse that is conducted to the ventricles. The arrhythmia is terminated by breaking the cycle that is circulating within the AV node. This may occur spontaneously, by application of a vagal maneuver, or by use of medications such as adenosine, verapamil, or diltiazem, or a beta blocker. All it takes is momentary interruption of the reentry circuit to disturb conduction properties enough to terminate the arrhythmia. That's it for part 2. In our final part 3, we'll briefly review what we've covered till now by illustrating how to apply the systematic approach to interpreting an SVT rhythm. We'll then launch into the final content areas of rhythm basics, which are interpretation of premature beats and ventricular rhythms. Until then, remember this link for easy access to our material on cardiac arrhythmias. This is Ken Grauer saying goodbye for now.
Du plus loin que me revienne l'ombre de mes amours anciennes,